All right, today we're going to dive into a really fascinating paper by Zandberg and his team. They're tackling a huge question in locally advanced head and neck cancer. When it comes to immunotherapy, is timing everything?
Okay, here's how we're going to break this down. First, we'll look at the big dilemma in head and neck cancer. Then we'll get into the nitty-gritty of the concurrent versus sequential therapy arms. After that, we'll unpack the trial's pretty surprising results, dig into the tumor microenvironment to see why this might be happening, and wrap it all up with your clinical bottom line.
All right, Section 1. Let's really set the stage here and understand the challenge that this trial is trying to tackle. So here's the fundamental issue, and it's a big one. For more than 30 years, 3 decades, we really haven't moved the needle on survival for these high-risk, locally advanced head and neck cancer patients. It's like we've been stuck on a plateau.
So, the next logical step seemed obvious, right? Let's just add immunotherapy at the same time as standard chemoradiation, or CRT. But then, major phase 3 trials like Javelin 100 and Keynote 412 came out, and they just didn't show a benefit. That failure really forced everyone to ask a critical question. What if we have the right drug, but we're just using it at the completely wrong time? And that question is exactly what led to this study. This is a direct, head-to-head test of that very idea, timing.
So here's the setup. The investigators took 80 patients with this high-risk, locally advanced disease and randomized them. In the concurrent arm, they got pembrolizumab 1 week before chemoradiation even started, and then they stayed on it during and after. Now contrast that with the sequential arm. Those patients finished their entire standard 7-week course of chemoradiation first. Then, 2 weeks later, they started pembrolizumab. It's a pretty clean comparison of timing.
Now, it's important to understand the trial design here. They used what's called a pick-the-winner design. It's a really pragmatic phase 2 approach. See, the goal wasn't to definitively prove one was better than the other right now. It was more about figuring out which strategy was more promising. So the rule was simple. If both treatments were safe and effective, the one that had the better 1-year progression-free survival, or PFS, would be picked to move forward into a bigger phase 3 trial.
Okay, part 3. Let's get to the results. And honestly, this is where things get really interesting, because one of these timings clearly came out on top.
So based on that primary endpoint, the 1-year PFS, the sequential arm was declared the winner. And you can see why. It hit 84% progression-free survival at 1 year compared to 71% for the concurrent arm, a clear winner by the study's own rules.
But, that's just at 1 year. The story gets so much more compelling when you look at the longer-term data. At 4 years, look at the local regional control. The sequential arm is at a staggering 96%. 96! Compared to just 64% in the concurrent arm. I mean, that's a hazard ratio of 0.11. That's a huge, statistically significant difference.
And this wasn't just a fluke in loco-regional control. The trend was consistent across the board. You look at 4-year progression-free survival, 69% versus 49%. Overall survival, 83% versus 71%. I mean, every major outcome favored the sequential approach. It's just a really clear, consistent signal.
Okay, but before we get too carried away, it is absolutely critical to put these findings in context. And Dr. Mara Gillison points this out really well in her JCO commentary. Remember, this was a phase 2 trial. It compared 2 experimental arms against each other. There was no standard chemoradiation-only control arm. So what does that mean? It means we can't definitively say that either of these approaches is actually better than our current standard of care.
So the clinical results are pretty striking, right? But the big question is, why? Why did this happen? Well, this is where the study's correlative science, looking at actual tumor biopsies, gives us a really compelling hypothesis. Right, so this is the million-dollar question. Why was the sequential therapy so much better? If we can figure out the biology behind this, it's going to be key to really understanding what these clinical results mean for our patients.
Okay, so here's the theory, and it's based on biopsies they took during treatment. It looks like in the concurrent arm that 1 lead-in dose of pembrolizumab actually triggered this acute inflammation. And what did that do? Well, it seems to have recruited these immunosuppressive macrophages right into the tumor, and it also cranked up PD-L1 expression. So the big hypothesis is that this created a more immunosuppressive and ultimately a more radiation-resistant tumor microenvironment right before the chemoradiation was supposed to do its job. It's a total paradox. The drug meant to help might have actually undermined the next step of treatment.
All right, let's bring it all home. What's the clinical bottom line here? What are the big takeaways for your actual practice?
So if you remember just 3 things from this, make it these. Number 1. Timing is absolutely critical. Starting Pembro 2 weeks after CRT gave those dramatically better 4-year loco-regional control numbers. Number 2, the tumor microenvironment really matters. It looks like giving immunotherapy concurrently might actually create an immunosuppressive environment that causes radiation resistance. And number 3, and this is the big one, this is not practice-changing yet. These are fascinating phase 2 results. They should absolutely guide the next big trials, but they do not change the standard of care today.
So, this trial from Zandberg and his team leaves us with a really provocative thought, doesn't it? Is sequential timing the real key to finally unlocking the full power of immunotherapy in head and neck cancer? It suggests that for years, maybe we've been so focused on asking if we should be adding these drugs that we completely forgot to ask the far more important question, when?